Hello everyone, welcome back. Today we are going to discuss another important topic in critical care, that is invasive fungal infection. So why this emphasis on invasive fungal infection? Because we often notice we have fungal colonization, so whether to treat that fungal colonization or not. Secondly, earlier it was believed that fungal infection or invasion of the fungal or fungisemia in the blood is only seen when there is neutropenic sepsis. So it is quite predominant in neutropenic side of the patients or immunosuppressed patients. But now we do notice that we have certain strata of patients who do get fungal infections. Especially it got very much emphasized with the mucormycosis during COVID pandemic. And thirdly, the diagnosis of your invasive fungal infection. How difficult it is to diagnose your invasive fungal infection. The similar problem comes if you delay the therapy of your fungal infection, because the mortality associated with these fungal infections or your invasive fungal candidiasis or aspergillosis, anything, is quite very high. So today we'll learn what is this and what are the risk factors, how do we diagnose, what is proven fungal infection, what is probable, how it can be, and how do you treat it. Okay, so let's begin first with the risk factors. We know that the risk factors can be either neutropenic patients or non-neutropenic patients. Neutropenic patients, quite obvious, absolute neutrophil count less than 500 and having a febrile episode, that is febrile neutropenia. So they're better to have an empirical antifungal therapy and also try to diagnose them and try to evaluate it. In a non-neutropenic patients, now with the advent of broad spectrum antibiotics, with increased critical care stay of the patient as well as the usage of steroids, we do see a lot of fungal infections also emerging in this strata of patients, which is the non-neutropenic patients. So what is the most common fungal infections we get? Be it neutropenic, non-neutropenic, there is always an overlap, but mostly we get candidiasis, aspergillosis. In HIV positive or in immunosuppressed or hematopoietic stem cell transplant patients or organ transplant patients, we can always get cryptococcosis and mucormycosis, as we saw in the recent pandemic. So what is this invasive fungal infection is? Fungal infection being embedded into the deep-seated tissues or at least having hematogenous seedlings into the blood. So what are the risk factors here? Obviously, immunosuppression, any immunosuppression drugs or any prolonged usage of steroids or any disruption of anatomical barrier probably by a central venous catheter, or you have multiple drainage tubes or abdominal surgery with some lot of anastomotic tubes, drains, corrugated rubber drains and all those things which have pierced your anatomical barrier. Burns and trauma, because there is the protective skin tissue is lost. Parenteral nutrition and exposure to broad spectrum antibiotics, which the broad spectrum antibiotics will completely change your microbiota or your general flora of your body, and then you are definitely prone to fungal infection. So this is predominantly for even non-neutropenic as well as neutropenic patients. Neutropenic patients, we know we have the low immunity, but even in non-neutropenic patients, we do see that if you have any of these risk factors, always keep in the back of your mind that there could be prodrome of fungal infection also.